Good afternoon. On behalf of the Global Interdependence Center's Board of Directors, welcome to today's executive briefing. I'm Melissa McIntyre-Shaw, and I'm Vice Chair of Programs at the GIC. As a reminder to our guests, this event is being recorded and the replay will be available through the GIC website, which is interdependence.org. Today's executive briefing is the second of a program series designed by the Global Interdependence Center and Solve Long COVID initiative. Our topic is Long COVID, Research, Policy, and Economic Impact. Throughout 2022, GIC and Solve will bring together world-class immunologists, medical experts, policymakers, and economists to explore critical insights into defining and diagnosing long COVID, to share their thoughts on optimizing treatments and healthcare policies concerning long COVID, and to give us their analysis of its impact on the United States and global labor markets. I would like to personally extend a sincere thanks to David Kotok, longtime friend and ardent supporter of the Global Interdependence Center. In 2021, Mr. Kotok and the Solve Long COVID initiative made a specific gift to Global Interdependence Center to provide funding, sponsorship, and logistical support for this long COVID series. We thank him for his generosity and the dedication to researching and understanding post-infection diseases. Now, let me introduce our moderator, Emily Taylor. Emily is the Vice President of Advocacy and Community Relations for Solve M.E. She brings to the organization over 15 years of policy, organization, and advocacy experience in both the nonprofit and the government sectors. With 5 years experience on Capitol Hill, Emily contributes a keen understanding of both state and federal policy processes and how that affects patients. Prior to joining Solve M.E., Emily served as the Director of Policy and Advocacy for an award-winning autism organization. There, she spearheaded major overhauls in disability, early intervention, and education policies. She received a BA with honors in politics and international relations from Scripps College in Claremont, California, and earned her MA in American politics from Claremont Graduate University. But most importantly, Emily draws her inspiration from her mother, who since 1999 has battled myalgic encephalomyelitis and chronic fatigue syndrome, commonly known as ME/CFS, in addition to autoimmune and thyroid conditions. So she knows firsthand the difficulties and stresses that surround these issues like long COVID. Thank you, Emily, for joining us.
Thank you, Lisa, for that very kind introduction. I'm so happy to be here today. Our agenda will begin with a quick discussion between Katie Bach and Melissa Smallwood, followed by an audience Q&A. Ms. Katie Bach, who, thank you so much for joining us, is an expert in job quality and low-wage work. She has a particular interest in the incentives and structures that lead companies to underinvest in workers. Ms. Bach has worked with dozens of companies ranging from Fortune 50 to startups and on improving frontline jobs. Most recently, Ms. Bach was the managing director of the Good Jobs Institute, a nonprofit founded by MIT Sloan professor Zinip Ton. There, she helps companies build systems to maximize the motivation, productivity, and contribution of employees in ways that led to better business results. Ms. Bach has published numerous articles in Harvard Business Review, Politico, Forbes, and elsewhere in discussing the financial case for higher wages, why we need more than a $15 wage, and the need for corporate disclosure agreements on worker pay. She is the co-author of a forthcoming Brookings report about stakeholder capitalism. I'm also joined by Melissa Smallwood. Thank you so much for joining us today, Melissa. It's a pleasure to work with you once again. Melissa is a science and technology policy researcher with a background in neuroscience, psychology, social science, and disability studies. She is a recent graduate of Arizona State University's School for the Future of Innovation in Society, where she worked on her master's thesis with Brian David Johnson's Threatcasting Lab. Her current work explores the long-term policy implications of long-haul COVID-19 and other enduring consequences of the COVID-19 pandemic. Ms. Smallwood is working with the Solve M.E. research team to develop models and write a paper on the prevalence of economic impact of long-haul COVID in the United States. Other projects that Ms. Smallwood has worked on include developing the role of the National Laboratory System in early pandemic response and public assessment of human genome editing with the future of healthcare. Katie and Melissa, thank you both again for being with us today. Let's begin our discussion. Both of you are really accomplished writers with some really interesting work that's been recently published. Katie, would you take a moment to share about your recent piece and what impact do you anticipate long COVID will have on the current labor shortage?
Yeah, sure. So about, it was maybe 6 months ago, 7 months ago, a friend of mine who has ME/CFS reached out and asked me if I thought long COVID was playing any role in the current labor shortage. And I said, no. I mean, I was like, look, I haven't seen that anywhere. This is about a million other factors. But I couldn't let go of the question. And so I started playing around with some numbers, and I mean, sort of proverbially, my jaw hit the floor. And so what I did is I built out a scenario that I published at Brookings. And I found that kind of the summary is in my base case, about 15% of the US labor shortage could be attributed to long COVID. And I think the biggest takeaway of my piece, the reason I wrote it, was not just to call more attention to long COVID. And we know that people do tend to pay more attention to these things when we talk about the financial impact, unfortunately. But it was because I wanted to call for greater data collection. And the whole point of my piece was, under a set of very conservative, reasonable assumptions, we could have about 1.6 million people out of work at any given time during the pandemic due to long COVID. And these are conservative assumptions. For example, I assume that everyone who gets long COVID recovers, well, on average, recovers within 3 months, which we know isn't true. And my point was, the reason I need to make all these assumptions is because we don't have data. And what we need to do is we need to start understanding what is the full economic burden of long COVID. So that's the piece I wrote. It got a fair amount of attention. And, you know, in terms of long COVID's impact on the labor market, the fairly unsatisfying answer that I have to give is we don't know. And the reason we don't know is because we are not tracking this. And I'm going to get into a little bit of the wonky detail here because I think it's interesting. So there are two like big labor surveys. One is they're both out of like Bureau of Labor Statistics, Census Bureau, et cetera. One of them is the Household Pulse Survey. And this was developed specifically to see what the impact of COVID was on American families and households. The other is a much bigger, like longstanding labor survey that we do regularly, and that's where all of our unemployment numbers come from. We actually added COVID questions to that bigger survey. And as I said, we have an entire survey just dedicated to COVID, but just the way they're phrased, neither of them pick up disability due to long COVID. And that's not intentional. I think it was an oversight, right? This was being written in June of 2020 when we didn't understand, well, a lot of people didn't understand what kind of problem this would be. So my kind of big appeal is we need to add long COVID specific questions to these surveys. And until we do, it's very hard to answer what role long COVID will play in the labor shortage. I think it is, having played around with these numbers a lot over the course of months, I think there's no question it is playing a non-trivial impact. And the last thing I'll say about this that I think is important to call out is certain jobs make it easier to accommodate disability. For example, I work 100% remote. I have a set of chronic illnesses. And the reason I can work full time is because of the type of work that I do. I can work from home. I can be flexible on hours. For a low wage worker who is, say, in retail or food service or healthcare, the privilege to work from home just doesn't exist. Hours are not flexible. And as we know, in 2020, it was really a lot of those low wage frontline workers who were most exposed to COVID or who could not avoid exposure to COVID. And so it is the very people who bore some of the worst burdens of the pandemic. And we would assume that long COVID rates are higher among that group just because COVID rates were higher, who are now in jobs that are very difficult to manage when you have a chronic health condition. And so as we have this conversation and we think about the impact of long COVID, quote, on the labor market, I think it's just really important to remember that different parts of the labor market will be impacted differently. So let me pause and hand it over.
Thank you so much. That was really insightful. And I have to compliment you again on your paper from Brookings. It truly was a really fascinating read. And to that end, thinking about those numbers from the other side of things, Melissa, congratulations on your recent white paper. Would you be able to share a few of the key findings from your recent paper and specifically a little bit about the perspective from financial burden?
Yes, of course. So I was one of the co-authors on the Solve M.E. CFS's initiatives white paper on the impact of long COVID on American adults with a focus on the labor force. Emily, I actually worked on it with you, and I was the person behind the mathematical models that we were using to try and estimate the prevalence of long COVID in the United States based on reported COVID data. Just kind of a summary of that paper, we are using two models to try and estimate the prevalence of long COVID, looking at two different data sets that are attempting to quantify the prevalence of COVID infection in the United States. The first model looks at officially reported cases. These are the ones that you're seeing sent out by the CDC, reported by the New York Times and other media outlets on their COVID trackers. These are officially recorded PCR tests that are being sent by states and hospitals and local medical providers up to the CDC as an official count of COVID cases. So this data set, it gives us a floor of COVID cases that we know exist. However, it has been the case throughout the pandemic that this is a drastic undercount of cases. We aren't entirely sure how drastic, but there are multiple factors that have caused a lot of COVID cases to slip through the cracks and not be recorded throughout the pandemic. In the early stages of the pandemic, the problem was that there was a massive shortage of testing supplies and testing availability, which caused really only the most severe and symptomatic cases to be officially recorded, while people who had milder or asymptomatic cases not requiring hospitalization didn't get tested and just kind of bore it out at home as a cold. Some of these people ended up developing long COVID. And then as the pandemic has moved on, even as testing availability has increased from those early stages, there are still a lot of people out there who either haven't been getting tested or more recently are using rapid at-home antigen tests. We particularly saw this during the Omicron surge, where people would test positive at home, but those positive test results would not be reported in the official numbers. So because of that being a persistent problem, we know that the official case counts of COVID are not telling the whole story. And that brings us to our second model, which is a bit more speculative, but estimates about twice the number of COVID cases as the reported case model. And this is using data from the CDC's Community Seroprevalence Survey, which is a kind of a network of community antigen testing, looking for a specific antibody. It's called the nucleocapsid antibody. And basically what this is it's a biomarker in the blood that is unique to natural COVID infection. So it's able to suss out people who have some immunity from COVID from being infected with the virus, as opposed to having immunity from vaccination. And basically, by compiling the average prevalence of this antibody in the blood of these volunteers from these community samples, the CDC creates an estimate of what percentage of people in each state have had natural COVID infection. So that was the data set that we used for our second model to estimate how many total COVID cases there might be, which would include some of the unrecorded and asymptomatic cases. So essentially, the estimates that we found are that the reported case model estimates about 23 million cases of long COVID and about 7 million cases of what we are calling disabling long COVID. And basically the definitions of those categories are derived from large community studies looking at the prevalence of long COVID symptoms in a generalized population. Looking at the generalized population is very important for getting these numbers, because a lot of the earlier studies with long COVID focused disproportionately on previously hospitalized populations who generally had more severe illness and are at an elevated risk for developing long-term symptoms, but aren't necessarily representative of the risk for the whole population. So what larger studies that are focused on a more general non-hospitalized population have found is that about 1 in 3 people who survive COVID have at least one lingering long-term symptom, at least 6 months. Actually, depending on the studies, they usually look at 3 to 6 months post-infection. But other studies have found that there's quite a lot of persistence with the symptoms for people who are still experiencing them 6 months out. But going back to the prevalence rates, it's about 1 in 3 people experiencing any long-term symptom, and that's in our white paper, that's what we're labeling as long COVID. And of the people who are experiencing these long-term symptoms, about a third of them, or 10% of the total population, is experiencing what we're calling disabling long COVID, or disability from long COVID. So this is the subset of the population that is experiencing significant impairment in, for example, their ability to work or engage in activities of daily living as a result of long COVID. And this is the population that we tend to focus on for the labor market impact, due to the fact that most people who are experiencing this level of disability are no longer able to work at their previous capacity. They've either been forced to drop down to part-time work. Some of the very lucky ones have been able to get work accommodations, such as remote work, that allow them to maintain their previous level of employment. But some are experiencing such a level of disability that they have had to leave the labor market altogether at great personal costs for their finances. And now many are experiencing depleted savings, huge medical bills, and even very bad outcomes such as homelessness. So our low estimate for the number of people who are experiencing this, again, is 23 million people having any long COVID symptom, and 7 million and 7 million people who are at risk for serious adverse outcomes from this. And then when you look at the seroprevalence model, which estimates about twice the baseline number of COVID cases, the estimated number of long COVID cases also doubles to be about 43 million people experiencing any long-term symptom and 14 million people experiencing serious disability. And as would be expected, this comes at a great financial cost. So one of the financial factors that we looked at was the financial burden being put onto individuals through the combination of healthcare costs and lost income. And our lower estimate model estimates a personal financial burden of $386 billion up to the end of January 2022. And our higher estimate estimates about $511 billion in personal burden. And this is not even beginning to look at the ripple effects of this on communities and businesses and federal and state budgets and kind of all those larger impacts. But we know that that is going to be a serious emerging problem.
Wow, thank you so much, Melissa, and thank you again. It was a pleasure to work with you on that paper. And so really, I think that to distill that message down, what both of you were saying is that long COVID, whether you look at it from the labor market perspective of how many people are out of the labor market or from the whole prevalence perspective of how many people got sick and are still remaining to be sick, it's a huge problem. That this is really, whichever way you slice it, this is not a small problem, and there's going to need to be some action on the part of our communities, on our government, our leadership and business and private sector as well, to stem the tide of this loss. So, so in that idea, with that thought in mind, I'd love to hear from you both about, are there any specific actions or specific sectors that should be particularly on guard about the impacts of long COVID? I know, Katie, you already shared a little bit, but maybe we could dive into that a little bit more with more detail about the impact of these specific sectors or work environments.
So I can take that first. So I'm going to keep reiterating this, unfortunately. The answer is we don't know. I will say, kind of just logically, we know that there are certain populations within the US that had higher rates of COVID. We know that they are disproportionately represented among low-wage jobs. We can think of these as kind of this essential workers. This is often low-wage service sector. So like I said, retail, food service, low-wage healthcare, janitorial type stuff, warehousing, like all of that. And not surprisingly, that is where we are seeing the real labor pinch right now. But I think the other factor, other than just the demographics of who was getting long COVID, is, like I said, which professions have more flexibility to accommodate the people who are not as severe, the people who can still work and just need a different way of working. And again, it is those occupations, the kind of frontline, low wage, where that is hardest to do. I think there are a whole set of specific considerations around healthcare in particular, partly to do with long COVID, partly to do with, frankly, just burnout. I think that sector is going to be facing like pretty severe challenges in years to come. But if I were a policymaker, I would be really worried about those like hourly kind of low to mid-wage roles.
Thank you so much. And actually, I'll just add a follow-up question to that for Melissa. Same question to you, but I'll add as a follow-up. Since we're lacking a lot of the research to really determine in a granular sense the answer to these outcomes, if you could wave a magic wand, what research would you want to add to help answer some of these questions?
All right. So first of all, building off of the first question and Katie's answer as to what factors which sectors are most likely to be worse affected. I want to touch a little bit on some of the biology that we think is going on behind long COVID. So long COVID, particularly the more severe cases, has a lot of overlap with ME/CFS, which is what your organization primarily studies. And one of the defining hallmarks of ME/CFS is called post-exertional malaise. This is essentially a dysregulation of the body's energy metabolism system. Basically, the viral infection kind of breaks it, and as a result of this, people who have the symptom, when they are faced with physical or mental exertion, it basically forces their body into emergency mode, and it causes these energy crashes that can greatly exacerbate the symptoms of ME/CFS and lead to a much more severe disease course that can have impacts throughout basically the person's entire life. And one of the major risk factors for this is is a person overexerting themselves in the early stages of recovery and trying to push past this symptom, and contrarily, having the ability to rest and not overexert yourselves in those early stages of recovery, I believe, is associated with a lowered risk of developing long-term severe ME/CFS. So think about that, and then think about what the workload and the demands are for many of the professions that are already being hit most heavily by COVID. The ones I think about in particular, healthcare workers, educators, and service workers, in addition to warehouse workers. I know that there were meatpacking plants were a big had some big early super spreader events. But one thing that these jobs have in common is, in addition to being public facing, high risk of COVID exposure jobs, they're also physically taxing and do not provide individuals with the ability really to take the time off that they need to recover. And in many cases, it's the exact opposite. For example, with healthcare, you can see this being exacerbated by the labor shortage there. Instead of being able to take time off to rest, we have policies that are trying to force people back into these physical jobs as quickly as possible. And in cases where people are employed in these lower paying jobs, particularly like retail and service jobs, they don't have a choice in many situations because they have lower wages and not really any protections against being fired at will. So they have to go back to work before they medically should, because they live paycheck to paycheck and they have to get paid and not lose their job. So it just creates this spiral that is going to have a heavy human toll.
Absolutely. Thank you so much for that. And actually, that might be a good opportunity to slip in a question for the audience, since you did mention ME/CFS, which I am very familiar with as a caregiver for my mother who suffered with this disease for many years. And it's been noted several times how there is a lot of similarity. And so we're drawing a lot of understanding and analysis about long COVID from the understanding of ME/CFS, since it's the most documented disease in some regards that we have in terms of what happens after a viral infection and what these patients are experiencing. So I'll just pause there and note that Cynthia Johnson asks us, Many of the long COVID with long COVID are being or will be diagnosed with ME/CFS. Can you please distinguish between ME/CFS after COVID versus disabling long COVID? And I think that's a question that both combines a little bit of what your paper, our paper worked on, Melissa, and also distinction between ME/CFS. So I just wanted to answer that alive and note that ME/CFS is diagnosed by a clinician in a doctor's office by multiple factors, including a case history, and there is no specific biomarker or what we would call a magic test for ME/CFS. You can't take a piece of blood or a tissue sample and find out, boom, that looks like ME/CFS. Well, it is by definition documented by the symptoms and the natural history of progression of the disease. And so we're also using that same approach to long COVID because there is no, at this time, no biomarker for long COVID. There's no test that we can use to exactly find out this is long COVID or this is not. So, so the diseases are very similar in that regard. And so we're using a lot of overlapping mechanisms to study both, including how that impacts the labor market and what the day-to-day lives of these folks end up looking like when they suffer from specifically the symptom post-exertional malaise over a long period of time. So I just wanted to interject with that question, and thank you so much, Cynthia, for asking it. So that would like to move on to another question that has been popping up. Specifically about our country's working women. We already know that women bear a disproportionate burden of caregiving roles, both paid and unpaid caregiving, and that we can expect an impact on long COVID specifically in these sectors. So how can employers, friends, society at large look at this particular issue of women in caregiving roles and long COVID? And are there any interesting analysis, insights, or solutions that we can find by looking at from the problem from that particular angle? Katie, if you'd like to take that first.
Yeah, so unfortunately, I don't know of any analyses that look at this specifically. I think the question is, I mean, the point that the questioner is making is exactly right. We know this is going to be a disproportionate burden. You know, again, I kind of go to what would I do if I were a policymaker? And I think one of the first things that I would do is look into what kind of social support can we give for caregivers in general. Frankly, this is something that we should have, personally, I believe we should have done long before long COVID was an issue, but it is even more urgent now. One thing I didn't mention in my paper, I did not include caregivers as part of the long COVID employment impact. They almost certainly are. People who have family members and loved ones who are severely affected by long COVID, many of those people are having to reduce hours or leave their jobs entirely. You know, we talk a lot about, well, what is the impact on the economy and what is the impact on specific sectors? And I think sometimes it's easy to forget that the economy is made up of the people in the economy, and the impact of losing two incomes, right? Because like you as a caregiver maybe have to leave your job or take on reduced hours, and the person who's severely ill has to as well. It's just devastating. And so like first and foremost, I will always say we need to collect the data on it, which is a whole separate thing. And I have lots of on that, but we know what the data are going to say. And so the next piece is we need caregiver support in place.
Absolutely, couldn't agree more. Melissa, did you want to answer that as well?
Yes. So one policy suggestion that came up in my thesis work, also looking at long COVID, for trying to ameliorate the impact of long COVID and caregiving on family members would be expanding the availability and insurance coverage of things like long-term care and palliative care. So there are services that exist to manage symptoms and improve quality of life and take some of the caregiving responsibility off of family members for people who are seriously ill. However, in the majority of cases, this type of care is associated with and sometimes only covered for people who are believed to be in their last 6 months of life. With the conception of it being that it's for very elderly or terminally ill people, such as people in the last stages of cancer. And this kind of leaves a gap for people who are experiencing serious long-term illness, but are not at immediate risk of dying from it, and are not in what we would be considered to be their final stage of life. So one potential policy action that could begin to tap at this extremely deep can of worms for how we help caregivers would be more investment and more coverage and availability of types of long-term care that are focused more on the wellness of the individual instead of just like short-term rehab programs, because that's not really what people with long COVID and other types of long-term chronic illness really need. And with that also comes just a reevaluation for how we think about disability, and kind of breaking out of this binary of either like short-term acute illness that you rehab and recover from and eventually become quote unquote well and normal again, and terminal illness that you get in old age and die from, because there is a middle ground to that, and we're going to be seeing a lot more people at younger ages experiencing this form of disability.
Wow, that's so insightful, and truly the idea that disability is not the end, that there's still there's still a very robust work life that can be had in those gray areas. I love that for the description, rather than just a disabled or not disabled. Excellent. So thank you both for that those insights. I'd like to move to another question that came from the audience. This one's from Diane. Diane, thank you for your question. Diane asked, do you have data on the protection that you have from the disease? And I think just to clarify a little bit more, I think that both means natural protection and vaccine protection. And I know, Melissa, that we actually worked some of that into our modeling. So I'd love to hear from you first a little bit about how those protections can work. And then Katie, looking from the other side of aspect, if you might want to take that next and answer a little bit about workplace protection, and maybe expanding that from the other perspective of how those different professions we described can have protection in the workplace for their employees. Melissa, if you want to take that first, and then Katie, jump in whenever.
Yeah. So this is a good time to ask the question about how much protection both vaccines and prior infection provide, because that is really in flux right now with Omicron and some of the new variants that are emerging. So just an overview of what we went through creating our models with Omicron. We had our first model, which was based on Delta, created in November of 2021, right before Omicron happened. And the assumption that we were making in that model is that breakthrough cases were relatively rare. And for our kind of macro level population analysis, we kind of just consider them to be insignificant. We basically made the assumption that most to all cases of COVID that were occurring in unvaccinated people. And Omicron completely changed that game because of the number of breakthrough infections that we were seeing in vaccinated people. So some of the early data that we were able to gain from New York's early Omicron outbreak is that about 10% of total cases in the initial Omicron surge were breakthrough cases. And the way that we factored this into our model is basically using the vaccination rate of each state to try and estimate how many cases were in unvaccinated people versus in vaccinated people during the Omicron surge. And once those were separated, we basically analyzed them using different risk pools. So in terms of the amount of protection that vaccination provides, we had some data out of Israel that found about 66% reduction in long COVID symptoms in breakthrough cases. So that ended up in our model being people who got a breakthrough infection had a 10% chance of developing long COVID versus a 30% chance of developing long COVID if they hadn't been vaccinated. So vaccination does provide protection against severe illness. The protection against long COVID, as would kind of be expected, we don't 100% know, just because Omicron and the breakthrough infections that it's been causing are so new that we don't have longitudinal data on it yet. However, there are cases of people who have breakthrough infections developing long COVID, unfortunately, so it's not foolproof. And also, unfortunately, there is increasing evidence that Omicron BA.2 and some of these new Omicron subvariants that are starting to emerge have greater immune escape. So one thing that I think I'm kind of expecting to see as these variants continue to spread is more cases of breakthrough infections and reinfections. And unfortunately for us, those are really difficult to track because our the data that we have been using to try and assess these unreported COVID cases, which is seroprevalence, is not sensitive to reinfection. It's just a binary of yes, you haven't infected, or no, you haven't been infected. So assessing that is going to be a really big challenge moving forward. And I guess, Emily, bringing back your, if I could wave a magic wand question, probably finding some way to keep better track of that and also keep better track of COVID cases in general, since we're kind of sabotaging most of our methods of tracking it. That would be on my wish list.
Absolutely. Tracking. I hear that. Well, thank you so much, Melissa. And Katie, to you. So looking at the same question from the protection side of an employer, what are some recommendations would you have, or some insight that we can glean about that aspect of protection for employees?
Yeah, and this is tricky. So in addition, I am a non-resident senior fellow at Brookings. I'm also the chief business officer of a pizza company. So we've got about 60 shops, got about 1,000 employees. So I am an employer. I think I'm going to kind of take a step back on this one. One of the things that I have been emphasizing that really popped out of my research is that we're making cost benefit analyses every day, all of us around COVID, right? Do I go to this party? Well, it's going to be really fun. They're not testing people beforehand. Do I go see a movie? Do I do this? Do I stop wearing masks indoors? And we're making these assessments with inadequate data. So both at a societal level, because we don't understand the economic, or let's call it personal burden of long COVID, but also on an individual level. The reason I raise this is because there are two ways that I think of protection from an employer perspective. One is, what can employers do to protect people who really want to be protected? So someone like me, right? I'm 100% remote because I can't put in the level of protection that I would need to be in person, which is like everyone testing every single day, everyone wearing an N95 all the time, right? And so I think this becomes a very challenging question of what level of accommodation should employers make. and personally, I tend to think that like wearing an N95 isn't that extreme. I mean, there are other reasons I'm not in person. Like I could ask everyone to wear an N95. So if I were an employer, I mean, I am an employer. If I were a different employer, I think I would put in place a pretty high level of protection if my kind of more vulnerable, more concerned people wanted to be in person. In my case, I don't. So this is irrelevant, right? But there's another way to think of protection. That is the like protect the vulnerable / concerned. There's another way to think of protection, which is every employer should be trying to prevent transmission among their employees, should prevent their employees from getting infected because they know there is this risk of long COVID. I mean, there are other risks with COVID as well, but for many of us who, you know, in my case, our employee base is very young, probably relatively healthy, mostly vaccinated, you know, like given all those factors, it's long COVID is probably the higher concern. The challenge you face is your employees don't always want to be protected, right? So let's say you've got a lot of, 19 to 25-year-olds, they're out on the town, right? They're not wearing masks indoors. So in our case, we do still mandate masks for all of our employees. They're not doing that anywhere other than at work. So I think these questions, it is very easy, especially for someone like me who, wants to be included in society, it is very easy to default to we should just take the most stringent level of protection allowable. But it is more complex than that in practice, unfortunately. And sorry, that was a very equivocal answer, but these are nuanced, difficult issues.
These are equivocal times.
Right.
That's so insightful. And that's definitely something that I think I wrestle with as the loved one of somebody who's high risk, is that I have to measure that in my behavior. That the do I go to that party because it would be fun is very different when I'm carrying the health of my mother in addition to my own health. And I'm making these decisions for more than just me. So I can say I wrestle this at a very individual level. And I'm not surprised that we need to wrestle with this at a societal or a firm level either, because these are hard questions. And we sort of have to wrestle with these issues of public good and safety and protection, considering both our most vulnerable and our least vulnerable in the same settings. So I'm really glad you gave that answer, because it is a nuanced question.
And I think to me, what this goes back to is we need full information when we're wrestling with it. And right now, we just don't have full information. Most people do not understand either the severity of long COVID or the likelihood of getting it, right? And so these are complex, gray, nuanced issues, but you need full information to wrestle with it. So for example, my husband, he's an attorney who works for the federal government, and he has had to ask his entire part of the office to mask, and to take precautions with him because of me, and they get the risk, so they're able to make that trade-off. When people don't understand the risk, it becomes a harder ask.
So information is key. Absolutely. Thank you.
Yeah, I just wanted to add in, Emily, you said most vulnerable and least vulnerable. We don't even know what least vulnerable is when it comes to long COVID, because it is not a perfect correlation with the initial disease severity. Like there are people who have mild and asymptomatic cases of acute COVID who are disabled by long COVID now. So the risk calculation for even for young people when it comes to long COVID, people really do not have the data to make that risk assessment. And
when you're young and healthy, it's very hard to imagine being permanently sick. And this is another, as we think about employer protection, and not just employer, like kind of what is the duty of all organizations and of society, I do think education is critical, right? I mean, that's what we're doing on this call, but I think more broadly, it would be helpful, rather than putting the entire burden on the people who self-identify as being more vulnerable, which is effectively what we have chosen to do as a society, it would be helpful if we could communicate more effectively that, in fact, all of us are vulnerable in this way.
Absolutely. So I'm going to cut this conversation short, as interesting as it is, but I want to make sure we have time for all the questions, and we have some really good ones coming up. So David writes to us, if we're short between 3 to 5 million people in the U.S. labor force, let's say, taking the average of a couple different estimates from our experts so far, and to confront the rising wage rates and face a political divide, which is an impasse to immigration, how do you propose to restore equilibrium in a labor force and labor force economics, other than by seeing much higher wages and thus bringing more people back to the labor force? And that would mean, of course, a 2 to 3% higher labor force participation rate. So other than that, what other way is there to overcome long COVID-induced labor shortages in order to make up for those gaps of people missing from the labor force?
Yeah, first I will say I assume the spirit of the question is wages are a no-brainer, because to me, wages are a no-brainer. My writing is about low wage work and frontline workers. And the truth is most companies can afford to pay much higher wages than they do. In many cases, at no impact to profitability, right? If you build high productivity frontline systems, you can actually invest a lot more in workers. So wages is the obvious one, for a million societal reasons. Beyond wages, though, as we were saying, number one has to be accommodation, right? And you are already seeing this. So at this point, I'm recruiting for a number of roles for my company. If you don't say that the role has the potential to be essentially 100% remote, you can't compete in this labor market. And so that is one example. As I said, there are obviously certain roles that can't be 100% remote, but you need a set of accommodations so that people who are struggling with illness, or people who have bowed out for other reasons, such as being a caretaker, can engage on terms that work for them. Of course, another thing, and we say wages, we should also think about wages and benefits. There are a number of benefits that are so compelling, people will take a job to access them. We're not very good at giving those. And there are benefits that are particularly helpful in the midst of a public health crisis. These include unlimited paid time off, certain types of health benefits, much better disability insurance. So, I was reading our company's disability policy when I joined, and it effectively ruled out conditions. It actually specifically ruled out chronic fatigue syndrome, which means it could effectively rule out long COVID, right? So obviously we had to change that. Anyway, so you have general accommodations, you have specific investments and benefits. And we say we're at an impasse when it comes to immigration. I will argue that if the labor market stays as tight as it is for much longer, that political impasse will start to become less of an impasse. The corporate lobby is extremely powerful, and they are really struggling to hire, and it is costing them a lot of money. And so I think at some point, this might become an immigration question. And then finally, this isn't a labor market intervention, but we need treatments for people with these illnesses so that they can get back to work. I was diagnosed with ME/CFS. Turns out I have EDS, which is a connective tissue disease. I have mast cell activation syndrome, which, we're seeing all over the place long COVID. I have POTS. I was completely bedridden, and now I'm working full time. That isn't possible for everyone. I have access to all sorts of healthcare, but without those very few physicians who actually do this work, I would no longer be working. So we need much greater accessibility to physicians. We need much more research. We need affordable medications so that people like me don't have to stay out of the labor force forever.
Hear, hear. Thank you so much. Melissa, would you like to add to that question or comment?
I think that Katie pretty much covered it. Although I would like to add that just getting people back to work shouldn't be the sole goal of getting treatments for long COVID. I think that we also have to couple reducing the level of unnecessary human suffering in there.
Absolutely. I think that's a priority for all policy conversations, is ultimately improving the outcomes for the people we serve. So with that, we're pretty much out of time today. So Katie, Melissa, thank you so much for a fascinating conversation and discussion. And thank you for spending time with the GIC and Solve Long COVID communities. We look forward to continuing this series, Long COVID Research, Policy, and Economic Impact. We are also very excited to share that the program's signature event will be taking place on Thursday, May 19th. We will be joined by a variety of speakers, including Obed Amate, Executive Director of the Solve Long COVID Initiative, and Bill Kennedy, Board Chair of the Global Interdependence Center. Registration for this event is now available at GIC's website at www.interdependence.org. And before we close, just a reminder that a replay of today's executive briefing will be available on the GIC website beginning tomorrow. That website again is www.interdependence.org. Once again, I'd like to send our sincerest gratitude and thanks to David Kotok for his generous gift in funding and supporting the Long COVID program series. And as we conclude, you'll see a quick survey will pop up as you log out. It takes about 30 seconds. Your feedback is so important to us, and we really appreciate you letting us know how we can improve our programming. We take your concerns and comments very seriously, and we welcome them. Thank you so much once again for your attention, and have a wonderful afternoon or evening for those of you on the East Coast.